Okay, so let's unpack this first major structural hurdle. Stakeholder interdependencies.
Right.
The research literature has long confirmed that stakeholders, both internal, doctors and nurses and external like patients and suppliers, they all form this intricate web.
A web that profoundly influences the overall health and ultimately the success of an organization.
But that web is, well, it's rarely a smooth or simple thing, especially in these huge public systems.
Oh, absolutely not. It's often inharmonious, as some researchers put it.
Yeah.
You have this collision, this constant conflict, and then convergence of different interests, different power dynamics, and all the varying levels of urgency.
It's not some clean org chart where you can just draw lines from one box to another.
No, it's a messy matrix. It's a tangle.
And when you shine that light on the NHS, you just see that friction amplified, don't you?
Massively. I mean, even as far back as 2014, the NHS was already being labeled a fragmented system.
And that's not getting any better.
More recent analysis just confirms it. That fragmentation creates this incredibly complex interplay of interdependencies. And that's what shapes the entire UK healthcare landscape.
So applying a framework like Rigby's here, it must be a real challenge. You have to start by just acknowledging how messy it all is.
You do. And in a complex public service model like this, leaders often face biases. They have to decide whose interests are legitimate and whose aren't.
And they tend to prioritize based on who's making the most noise.
Exactly, based on perceived power or the immediacy of a concern or just the raw urgency of a demand. But the framework forces you to move past that.
How so?
It demands systematic recognition and measurement, and then management of value creation across all stakeholders. It doesn't matter who's shouting the loudest.
Okay, so if we try to strip away some of that complexity for a moment, who are the absolute core players, the ones whose interdependencies really drive the whole machine?
At the most fundamental level, you've got four central pillars. You have the patients, of course, the ones receiving care, then the healthcare professionals delivering it,
Right.
then the government, which sets the funding and the overarching policy, and finally, the management layer that has to try and implement all of it. Those four are just non-negotiable.
But the actual decisions, the policies themselves, they're influenced by a much, much broader cast of characters.
Absolutely. Policy gets shaped by everyone. NHS commissioners, GPs, who are kind of the gatekeepers to the whole system.
Local authorities, too.
Local authorities who handle public health and social care. Then you've got the academics doing the research, the countless patient advocacy groups, suppliers. Yeah. It's a multi-layered ecosystem.
And every single decision must send ripples across that whole landscape.
Every single one.
Let's focus on the internal structure for a second, because that seems to be where so much of the day-to-day tension lives. It's not just a simple management versus staff thing, is it? It's more like two different professional cultures colliding.
It is. It's highly nuanced.
Yeah.
And it very often pits clinical autonomy against corporate efficiency.
So you have the healthcare professionals on one side.
Right. And their training, their whole instinct, is to prioritize clinical independence. They want the best possible outcome for the individual patient sitting in front of them.
And on the other side,
You have the managers. And their mandate is the efficient management of increasingly scarce public resources. So it becomes clinical excellence versus financial efficiency. That tension is just, it's baked into the DNA of the NHS.
So with that kind of perpetual conflict at its core, how does the system even hold together? It must need some kind of North Star, a unifying purpose that can rise above all the day-to-day squabbles over budgets and bed space.
It does, and it has one. The guiding purpose officially is to deliver high-quality service for all.
And that's what's supposed to unite all the different tasks and objectives.
It's the attempt, yes. The source material we're looking at here actually references the concept of a brand mantra.
The brand mantra.
Yeah, think of it as a short philosophical guide, something that's meant to steer every decision, every resource allocation.
And let's be clear for you listening. When we say brand mantra for an organization like the NHS, we're not talking about advertising slogan.
Not at all.
This is about philosophy. It's about what the organization fundamentally stands for. And the source material breaks this down into three core parts.
That's right. We've adapted the concept for this public service model. The NHS's purpose, its mantra, is defined using three modifiers. First, the emotional modifier,
Which is humanity.
humanity.
Yeah.
Second, you have the descriptive modifier, which is public trust,
And third, the brand function, what it actually does.
which is simply healthcare.
Humanity, public trust, healthcare. So that single phrase is meant to influence everything, from who they hire to where they spend billions of pounds.
That's the idea.
But let's dig into that public trust element for a second. What does that descriptive modifier practically mean for the NHS? It can't just mean that people don't actively distrust the system.
No, it goes much, much deeper than that. In this context, public trust means that the public, who are the primary stakeholder, remember, they must have absolute confidence in the system's reliability.
In its equity, too.
And its equity and its capability to serve absolutely everyone, regardless of their circumstances. It means the system has to constantly maintain its legitimacy as a universal service provider.
So it's a proactive thing. It's not just about avoiding scandals.
It's about continually proving its worth. It's an ongoing relationship management. And that mantra, it also influences the expectations of all the other stakeholders. It helps attract and retain people, staff, whose personal or professional interests align with that core mission.
That makes a lot of sense. So understanding these incredibly complex interdependencies and this, high level, sometimes aspirational brand mantra, that's the crucial groundwork.
It is.
Because the next step in this Rigby framework is where we stop talking about philosophy and we start talking about hard data.
Exactly. It's about defining who and what the NHS actually prioritizes. Because without the data, without those weights, the mantra is just a nice sign on the wall.
The weights tell the true story.
The weights tell the true operational story.
Right. This is the part of the deep dive where we really get forensic. We're moving into the quantitative analysis, the empirical heart of this whole strategic framework.
But before we even get to the NHS numbers, we have to hammer home this major finding that supports the whole approach in the first place.
Which is the myth.
The myth that focusing on all your stakeholders somehow harms your shareholders.
It's a zombie myth, isn't it? It just refuses to die in certain boardrooms.
It really is, and the evidence against it is just overwhelming. Maximizing comprehensive stakeholder value does not come at the expense of shareholder value. For long-term endurance, the opposite is true.
The researchers point to so many independent data sources on this.
They do.
I mean, you take the rankings from the Drucker Institute, for example. Their whole scoring system looks at 5 key areas.
Right, it's not just one metric. It's customer satisfaction, employee engagement, innovation, social responsibility, and then, yes, financial strength.
And they consistently find that the highest ranking companies, the ones creating the most value for all their stakeholders, they generate shareholder returns that are comparable to, or often even better than, their peers who are just chasing short-term profit.
And if you want a really specific return on investment number, just look at the work done by Just Capital.
They're the independent nonprofit, right?
Yes, and they track company performance against these comprehensive metrics. And since 2016, they found that companies in the top half of the Russell 1000 index for their combined impact on communities, the environment, employees, and shareholders.
Okay.
They outperformed the index by a massive 6.55%. It's just better business. It's more resilient business.
So the lesson here for the NHS, which is a zero-profit entity, is crystal clear. Focusing on its stakeholders, the patients, the staff, the community, that's not some charitable sideline. It is the core strategy for its organizational health and its long-term public benefit.
Precisely. But even with all that clear evidence, organizations still tend to prioritize based on instinct or political pressure, not on data.
We see high-profile CEOs who commit to stakeholder governance, but then they try to implement it by gut feeling.
And gut feeling, instinct, it gets overridden so easily when the budgets get tight or when there's a change in leadership. You need a strategy that's built to endure.
So how does a massive non-business system like the NHS even begin to define its priorities, given that it doesn't have shareholders to answer to?
Well, the NHS identifies 6 core functional priorities. These are the things that are deemed absolutely necessary for effective service delivery.
And these are drawn from extensive literature and official reports?
They are. And they represent the objectives whose concerns must be most recognized and satisfied.
So what are they?
They are patient-centered care, clinical excellence, operational efficiency, workforce well-being, accountability, and financial sustainability.
Okay, on the surface, that looks like a perfectly balanced, holistic list. It's 6 things any world-class health service should be prioritizing.
It seems that way.
But this is where the data-driven framework pulls back the curtain and reveals the truth behind all the public statements.
This is it. We have to assign empirical weights to these priorities. We do that by analyzing the NHS's own annual reports and its long-term plans to see where the system actually spends its strategic capital, its time, its money, its focus.
In the analysis, it sets the total weighting at 10.00s across these 6 priorities. This is the ultimate proof point of whether the NHS is really acting on its philosophical brand mantra or just paying it lip service.
Exactly.
Okay, so let's reveal the weights. We'll go from the highest priority down to the lowest.
Let's do it.
At the very top, the highest priority is clinical excellence. It comes in at 1.90.
And that makes total sense. It reflects the strong historic influence of healthcare professionals and that deep-seated professional culture that's focused on medical standards.
Right behind it, practically a statistical tie, is workforce well-being at 1.88.
Which again makes sense. It reflects that intense post-pandemic realization that staff retention and morale are, frankly, existential threats to the whole system.
Then we have patient-centered care at 1.79. And that's followed pretty closely by operational efficiency at 1.75.
So far, so good. The top 4 priorities are all grouped relatively closely together. It suggests a high degree of strategic effort in all those areas.
But
Then we hit a really significant drop-off.
the 5th priority, financial sustainability, it falls all the way down to 1.41.
And then we get to the absolute lowest weighting. This is the big reveal from the analysis.
Accountability.
Accountability at a mere 1.27.
Wow, 1.27. That is substantially lower than everything else on the list. It's nearly a 40% difference from clinical excellence at the top.
It's a huge gap.
I have to say, I would have thought accountability, being transparent, being answerable to the public, would be right up there with workforce well-being in a public service model that's literally founded on the idea of public trust.
You think so?
This gap. This is the central insight of the entire analysis.
It is the accountability deficit. This finding that the system places the lowest strategic weight on being answerable to its stakeholders is the critical disconnect that this data-driven framework uncovers.
And the framework tells us immediately, this is the area.
This is the area that needs urgent strategic development.
So what are the real-world consequences of treating accountability as your lowest priority? I mean, it can't just mean you fill out fewer forms.
No, it results in a kind of systemic blindness to certain strategic needs. The source material points out that this low weight actually stems from an unsustainable flow of planning and reporting.
So because you don't prioritize being accountable to your community stakeholders.
You fail to recognize and then implement the strategies you need to address major, well-documented challenges.
Like the massive demand being placed on the NHS by the aging population. I mean, that's one of the biggest crises facing the entire system.
Precisely. Researchers have noted that the very strategies required to manage this rising demand are severely limited by the low strategic weight placed on accountability.
How so?
Well, managing that kind of high demand requires moving toward a genuinely patient and community-driven healthcare strategy. But if accountability to that community is weighted so low, the system simply won't prioritize or fund the necessary initiatives.
The initiatives that would integrate the public's voice and needs into resource allocation and long-term planning.
Exactly. So the system is, maybe unconsciously, prioritizing its clinical success and the happiness of its staff over being transparently answerable to the very community it's sworn to serve.
And that low weight on accountability is actively preventing it from even seeing the solutions for its most urgent public health challenge.
That is the strategic cost of that 1.27 weighting. It prevents the organization from making that necessary leap into community-centric solutions. It confirms that the aspirational brand mantra of public trust is not truly reflected in the operational strategy.
So the Rigby framework is iterative. Once we have this bombshell finding the 1.27 weight, we then have to validate it.
Right, using both external perceptions and looking at the internal data gaps. This is the reality check phase of the whole process.
Step 1 is external insights. This is about using external rating agencies or public opinion evaluators to measure performance.
And the point here isn't necessarily to agree with whatever the external ratings are. It's to use them to challenge your own internal biases. To ask, are we perceived in the way we think we are?
So let's go back to the health tech business client for a second to see how this external scrutiny gave them a strategic jolt.
Okay, so health tech used these multi-criteria analysis tools to figure out its net value creation.
How did that work?
They translated all this complex performance data, how satisfied various stakeholders were, into a single uniform scale. It ran from plus 100.
Which means exceptional value creation for that stakeholder.
All the way down to minus 100, which meant the company was actively destroying value for them.
And then they weighted those scores based on their strategic importance. So maybe customers are weighted at 15% and shareholders at 21%.
Exactly. They summed them all up, and the outcome was pretty stark.
What did they find?
Health tech discovered it was performing well for its shareholders and for a certain subset of its customers, but it was actively diminishing value for other critical groups.
Like who?
Its discontented workforce, its suppliers, and local communities where it operated. Its total net value creation score was surprisingly low, much lower than key competitors who had better relationships with their staff and communities.
So that external view forced them to confront the fact that their internal focus was just way too narrow.
It did. So applying that same lesson to the NHS, our external insights come from independent bodies like the Policy Institute, the Health Foundation, and Ipsos MORI.
The ones that conduct all the detailed public perception surveys.
Exactly. They gauge public trust, patient satisfaction, perceived ethical practices, all of it.
And what do they find? Does it back up our 1.27 finding?
It reinforces it perfectly. The external perception metrics are deeply negative in some really key areas. For instance, patient satisfaction and experience has been described by researchers as deeply negative.
And it's the same for staff, right?
Similarly, external reports show well-being and employee satisfaction are overwhelmingly reported as negative.
So this widespread public dissatisfaction, especially around patient experience and staff morale, it seems to be the direct external reflection of the system's failure to prioritize accountability.
That is the critical link we have to draw here. If you don't prioritize being answerable to the public, that 1.27, the negative perceptions about the quality of experience and how staff are treated, they inevitably spiral.
The external data is basically shouting at the system.
It's shouting that the system lacks balance because of this low strategic weight. It confirms that the NHS needs to start measuring and prioritizing metrics that rigorously enforce answerability.
Okay, so that brings us to step 2, internal data analysis. You take that external shock and you refine it with your own insider knowledge to build a better strategy.
Because often the external view measures the wrong thing, or it measures the right thing in the wrong way.
The health tech case study is the perfect illustration of this, right?
It is. The CEO and his team, they looked really closely at how the external agencies were measuring customer satisfaction, and they found the agencies were focusing heavily on the second-tier customers.
The patients, the people who actually use the medical devices.
Right. But patients, and this is understandable, they don't know the engineering details of the equipment. They just know if it helped them feel better or not.
So the external view was skewed. It was measuring the impact on the wrong group.
Totally skewed. When health tech looked internally and focused on their first-tier customers, the physicians and the hospital administrators who actually buy the equipment, they found rampant dissatisfaction.
What's the problem?
Well, customer interviews revealed the product was overloaded with all these unnecessary features that just inflated the cost, made the device less reliable, and actually reduced its usability for the medical staff who had to operate it every day.
So those staff members were actively looking for alternatives.
They were. So the key takeaway for health tech was that your stakeholder priorities have to reflect your organization's own goals and its real-world operational experiences, not just vaguely trying to please the public or your shareholders.
So they pivoted their whole strategy.
They pivoted toward increasing usability and reliability for the physician, because they knew that would eventually lead to better patient outcomes and, for them, higher profits.
The NHS has to adopt a similar discipline then. Its internal data comes from this incredible range of sources.
It's huge. You have clinical records, operational data on things like waiting lists and resource allocation, comprehensive patient surveys, workforce metrics on retention and job satisfaction, and all the financial data.
All of that data gives us incredibly rich insights into efficiency, staff happiness, and financial sustainability. But does it align with that brand mantra? Humanity, public trust, healthcare.
For the most part, yes. But here is the massive gap, the one that perfectly mirrors that 1.27 weight.
What is it?
Crucially, while the system collects all this rich quantitative and qualitative data on efficiency and satisfaction, the internal reporting yields very low insight on accountability.
The system just doesn't prioritize collecting it.
It doesn't collect or analyze the information needed to measure the organization's transparent answerability to its stakeholders.
Which must make measuring stakeholder value in the NHS inherently challenging. You've got the multifaceted nature of healthcare and all these diverse, sometimes conflicting interests.
It's very difficult.
So how do you fix a data system that systematically ignores answerability?
Well, the source material suggests the NHS has to rigorously employ a combination of things.
Yeah.
Critical priority weights, major stakeholder interests, and performance metrics. But the single most decisive action is the mandate to assign a significantly higher weight for stakeholders whose main interest is accountability.
And that forces the translation of the external shock and the internal data gap into a concrete strategic mandate.
It's a structural change. It demands that the system stops just measuring how quickly a patient is treated and starts measuring how transparently the community was involved in the decision to allocate resources to that area in the first place.
So we've used the data-driven framework to identify this accountability deficit, the
Yeah.
1.27 weighting, and we've validated it against external perception and internal data gaps.
Right.
Now we come to the final, and let's be honest, often the hardest phase, implementation. How do you build a system to sustain this new, hard-fought focus across an organizational leviathan like the NHS?
Yeah, this is where we have to move past just policy change and get into organizational psychology.
Because a strategy is useless if it's not actually embraced by the whole organization.
Exactly. From the board all the way down to the ward clerk. The framework details 5 key elements that are necessary for sustaining this kind of profound change.
And those are?
Culture, structure, processes, redesign, and communication.
Okay, let's walk through what the implementation needs would be for the NHS, starting with culture and structure. How do you embed accountability into the very fabric of the organization?
It has to start by building a culture that consciously favors your priority stakeholders in every single decision. For the NHS, that means elevating this accountability mandate.
And structurally?
Structurally, it requires creating new organizational channels that actively increase cross-stakeholder collaboration. The analysis suggests establishing bodies where expert ideas from key stakeholder groups.
Especially the ones concerned with accountability, like community councils or patient groups.
Precisely. And those ideas have to report directly to senior management to inform strategy and, crucially, budget developments.
So that sounds like moving way beyond just simple patient feedback surveys.
It is.
It's about giving the stakeholders who are demanding accountability a real seat at the table where the strategic decisions and the budget allocations are actually being made.
Yes. It's about embedding their voices directly into the leadership metric system. The organization has to prove, through its very structure, that that low 1.27 weight is being fixed.
Okay, so next up is processes.
Right. The NHS would need to implement continuous departmental reviews that track value creation targets against this new, higher accountability metric.
So every department review, every single funding proposal, now has to prove it isn't just clinically effective.
But that it also upholds the accountability mandate.
That's right.
Every proposal has to be comprehensively stakeholder-oriented.
You have to make sure you don't solve the staff burnout problem while accidentally creating a new crisis for operational efficiency or public trust.
Exactly. That interdependency check has to be formalized into the approval process.
Then we have to tackle redesigning business processes. This is the operational reality of the change. Where should the NHS focus its improvement efforts once accountability is really prioritized?
Improvements must focus intensely on those areas that will give you the strongest, most immediate impact on your target value creation.
Which in this case means the areas that demonstrably increase accountability and trust.
Yes, and this necessitates rapid feedback loops. You collect feedback from your newly empowered stakeholder groups, you implement the subsequent changes quickly, and, critically, you grant departments greater autonomy to act on the localized data they gather.
So that change management can't be entirely top-down.
It can't. It has to empower local teams to be accountable locally.
And that brings us to the fifth element, communication. This is vital for controlling the narrative. But in a public service model, the concept of attracting the right stakeholder segments gets a little tricky, doesn't it?
Yeah.
How does the NHS apply a business concept like that when it's mandated to serve everyone?
This is probably the single hardest translation point between the business model and the universal service model. For a business, attracting the right segments means attracting profitable customers who align with your brand.
But for the NHS?
For the NHS, it means communicating with total honesty to attract those stakeholders, whether they're patients, staff, or community advocates, whose core interests align with the strategic goals of humanity, public trust, and healthcare.
So it's not about excluding people. It's about being really clear about what the NHS can and, just as importantly, cannot promise.
Precisely. The goal is to minimize attracting the wrong segments. Now, that doesn't mean people who are sick, of course. It means those whose demands might fundamentally conflict with the NHS's guiding purpose.
People demanding disproportionate resource allocation purely for personal gain outside of the clinical priorities.
Exactly. So transparent communication manages expectations, and it clarifies the very real trade-offs that are necessitated by a universal service mandate.
Ultimately, this entire sustainability system just ties back to resolving that core issue we found.
The accountability mandate.
Yes. The analysis confirms that fixing this low weighting is the mechanism that's expected to resolve so many of the documented failures in the NHS.
It is. Performance metrics have to be fundamentally re-engineered to recognize and to favor stakeholders whose main interest is for the NHS to be accountable to them.
And when you give accountability a higher weight, you force transparency.
You do. And that transparency is the necessary tool that's expected to unveil the specific areas where the NHS is failing, not just clinically, but strategically. And then to resolve those failures by adopting that crucial community-driven healthcare approach that the researchers suggest.
And that links all the way back to Section 3. This adoption of a community-driven strategy. That is the exact solution that's needed to address the existential threat of high demand from the aging population.
Right. You can't solve a community-wide problem with a purely centralized clinical strategy.
The shift is profound. It moves the entire definition of success away from just measuring efficient financial inputs and clinical outputs
To measuring the system's answerability and its responsive effectiveness to the public it was designed to serve. This is how you transform a system that was designed in the 20th century into one that's fit for the 21st.
So this deep dive has really shown us that a data-driven framework, one that was born in the corporate world with clients like health tech, can offer these powerful objective insights when you apply it to the most complex non-business entities like the NHS.
The synthesis is remarkably clear, isn't it?
Yeah.
The Rigby model didn't just point out that the NHS has problems, it methodically located the Achilles heel.
The low strategic weight placed on accountability.
Exactly. It highlighted that fundamental challenge for leaders, balancing the diverse, often contradictory, interests of patients, providers, the government, and management, and resolving that perennial tension between clinical independence and resource efficiency.
The core lesson here is the absolute necessity of moving beyond just instinct and political pressure.
Towards a methodical, data-driven approach for balancing all these divergent interests against the organization's core goals. That's what allows the system to endure and to truly serve its mandate.
So the ultimate recommendation coming out of this analysis is that a thorough strategy has to continue to value its top priorities: clinical quality, workforce well-being, operational effectiveness.
But it must place a special, decisive emphasis on dramatically raising the weight given to accountability. That's the strategic balance point. It's the point between meeting urgent, short-term operational needs and maintaining long-term viability and, most critically, public trust.
The model really did constructively unveil the precise niche that requires urgent development within the NHS to truly safeguard the health of the entire organization.
And the path forward from here involves continuous iterations of this model, meticulously managed change, and deep engagement through comprehensive analysis and in-depth interviews with all the major stakeholders.
By creating that stakeholder map, defining the guiding brand mantra, setting metrics that align the internal reality with the external perception, and then employing the right kind of analysis.
The NHS can vastly improve collaboration, accelerate effective decision-making, and ensure that leadership, resources, and communication are all aligned with innovation. And that's how it fulfills its commitment to humanity, public trust, and healthcare.
Which brings us to our final thought, something for you to consider. Long after this deep dive is over, we saw the true trade-off in the numbers. Accountability sits at 1.27, while workforce well-being is at 1.88, and clinical excellence is all the way up at 1.90.
A huge difference.
So here's the question. If balancing the NHS's guiding purpose requires actively prioritizing accountability, and that means giving it a strategic weight substantially higher than 1.27 over those other highly valued aspects, what specific real-world decision must the NHS leadership change tomorrow to reflect that new priority?
And think about the difficult trade-offs that implies. If accountability demands that a new community-driven strategy must come before a new initiative that's focused purely on staff morale, where do you spend the next pound?
It forces a really hard look at where the true strategic costs and benefits lie.
Something to mull over. Thank you for joining us on The Deep Dive.
Until next time.